Thank you for joining my lecture on Chapter 12, the Endocrine System, which can be found in the Human Body in Health and Disease textbook by Patton and Thibodeau. The study of the endocrine system can be traced back to traditional Chinese healers more than 2,000 years ago. And while scientists expected that there was some form of chemical communication that went on between various organs, the term hormone wasn't coined until the early 1900s. And hormones are the main regulators of metabolism, growth and development, reproduction, and they play an important role in homeostasis as well. And they are necessary for our survival. And not only do glands produce hormones, but the placenta and the stomach produce hormones as well. In this lecture, we are only going to cover the endocrine glands, but there are also other types of glands that we've talked about previously called exocrine glands. And the difference is that exocrine glands secrete their products into ducts that empty onto a surface or into a cavity. And two good examples are the sweat glands and the salivary glands. So up here on this top image, these are the different salivary glands, and you can see a duct here, you can see a duct here. So remember, exocrine glands have ducts, and then this here, you can see this little tube that deposits the sweat onto the surface of the skin. So exocrine glands have ducts, and they empty onto a surface or into a cavity. Endocrine glands do not have ducts. So as I mentioned before, endocrine glands do not have ducts. Rather, they secrete chemicals known as hormones into the intracellular spaces. And these hormones then diffuse directly into the circulatory system and are carried throughout the body until they reach their target cell. And their target cell has specific receptors on its cell membrane that allows that hormone to attach and enter the cell. Here we're looking at the primary endocrine glands, and you can see where they're located, starting in the brain with the hypothalamus, pituitary, and pineal glands, and then working our way down the thyroid, which is that butterfly-shaped gland that is right in front of our trachea. And then on the back side are four small little parathyroid glands. In the area of the mediastinum is the thymus. And then the adrenal glands sit atop of the kidneys. And then we have the pancreas there, which is situated near the stomach. And then in the female, we have the uterus that lives in the pelvic cavity plus the ovaries. And then in the male, we have the testicles that lie within the scrotum. So as discussed previously, endocrine glands secrete chemicals or hormones into the blood. So you can see in this image here, there's some sort of secreting cells, and those secreting cells secrete a hormone into the intracellular spaces, and then they diffuse into the bloodstream, picked up by the capillaries, and they travel through the bloodstream until they arrive at their target cell. And again, this is kind of another lock and key process where a specific hormone is going to fit into a receptor of a specific target cell that's going to elicit the desired reaction. There are two major classes of hormones, non-steroidal and steroidal hormones, and they differ in the mechanism by which they influence their target cells. Non-steroidal hormones, such as thyroid stimulating hormone, actually fits into a receptor at the plasma membrane but cannot enter the cell itself. So it's referred to as a first messenger. So The nonsteroidal hormone will bind to a receptor on the target cell's membrane, and this triggers a cascade of events inside the cell. One of the most common second messengers is something called cyclic AMP or CAMP. And that second messenger is activated, which causes a cascade of other chemical interactions to elicit the desired response inside the cell. Steroid hormones, on the other hand, are small enough and they are lipid soluble, which allows them to squeeze into or pass through the cell membrane by themselves. So the steroid hormone enters the cell membrane, binds with a receptor on or near the nucleus, and that steroid hormone is allowed to enter the nucleus, which then results in a formation of a new protein in the cytoplasm, which produces the specific effects on the target cell. A good example of that would be estrogen. Estrogen might affect breast development in the female adolescent. We've talked about negative versus positive feedback loops in the past, and remember, negative feedback loops oppose or negate a change in a controlled condition, where positive feedback loops temporarily amplify or reinforce a change that is occurring. So a good example of negative feedback would be when blood glucose rises and how that triggers the pancreas to secrete insulin, which helps to uptake sugar and turn that into glycogen so that it can be stored for later use. And then when the blood glucose levels are back to a normal level, then that negative feedback loop stops. Positive feedback loop, a good example would be uterine contractions during childbirth, where the uterus is contracting harder and harder and harder until the delivery of the infant is complete. As discussed, the regulation of hormone secretion is controlled by two types of feedback, either negative feedback loop or positive feedback loop. When there is some sort of situation in the body and it needs to go to work to maintain homeostasis, certain feedback may trigger secretion of a releasing hormone that targets another gland or triggers a secretion of that second gland's hormone. Again, this is a chemical communication that happens in a cascading type effect. There could be a releasing hormone that triggers the release of another hormone that regulates its target cells. And in turn, this is going to change their function to produce an effect that changes a variable to move back to its set point and achieve homeostasis. At the end of the day, the takeaway is that all of the levels of control are receiving and reacting to various types of feedback. And this is the most efficient and precise way for the body to maintain homeostasis. So when we're talking about the mechanisms of endocrine disease, one of two things can happen. Either the gland is producing too much, which is hypersecretion, or it's not producing enough. So this can be caused by certain types of tumors or other abnormalities of the glands. Oftentimes with hyposecretion, it may not be that the gland is not secreting enough hormones, but it may mean that there's something wrong with the receptors on the target cells. Maybe they're damaged or there's not enough of them, or sometimes they become insensitive to the hormone that is targeting them. And a good example of that is type 2 diabetes, which is diabetes mellitus. When there are several hormones that are either there's too much of a secretion or not enough of a secretion of multiple hormones, we refer to that as polyendocrine disorder. And endocrinologists, or those that study the endocrine system, have developed different types of strategies, which could be drug therapy, surgery, or the use of synthetic hormones or various types of other chemical treatments. Prostaglandins function like hormones, but they don't meet the typical definition of a hormone. Prostaglandins aren't made by glands, but they're made by the tissues themselves. Because they don't last very long in the body, they're only able to affect nearby cells. So what can they do? They can cause blood vessels to dilate or contract. They can form or destroy blood clots. They can open or close airways, contract or relax the gastrointestinal tract, stimulate uterine contractions, and other types of reactions. So doctors say that prostaglandins can be associated with painful menstrual cramping, the stimulation of uterine contractions during birth. They can also help with general healing properties like decreasing stomach acid or stimulating the release of mucus within the stomach. They can also help to decrease intraocular pressure and prevent glaucoma. They can decrease pain and inflammation or increase pain and inflammation. Naproxen, or Aleve, if you've ever taken that, actually blocks the creation of prostaglandins in certain tissues. But if we have too many of them, then they can lead to painful arthritis and menstrual cramping. And if we don't have enough, that could result in glaucoma or stomach ulcers. The pituitary gland is located deep within the brain and is very well protected, which tells us that it is a very important structure in the maintenance of homeostasis of the body. It is attached to the hypothalamus by a little stalk, and it's really two different glands kind of stuck together. There's the anterior portion, which we refer to as the adenohypophysis, and the posterior portion, which we refer to as the neurohypophysis. Now, adeno means gland, and neuro means nervous, and hypophysis is just a technical term for pituitary. So one portion of it, the anterior portion, functions like a gland, and the posterior portion functions more like nervous tissue. So remember that the hypothalamus, some of the neurons in the hypothalamus act like an endocrine gland, and they secrete chemicals called releasing hormones into the blood. And those releasing hormones act directly on the anterior pituitary to signal it to release hormones that then will act on other endocrine glands. So we're going to look at the different types of hormones specifically that the anterior pituitary and the posterior pituitary gland secrete and what they do. When I think about how the hypothalamus and the pituitary, the anterior pituitary, work together, I often think of it as like a chemical cascade or a waterfall. The hormones that are secreted by the anterior pituitary or adenohypophysis are the thyroid stimulating hormone, adrenocorticotropic hormone, follicle-stimulating hormone, luteinizing hormone, growth hormone, and prolactin. We're going to talk about each of those. So what are the functions of the major hormones of the adenohypophysis or anterior pituitary? Well, TSH or thyroid stimulating hormone stimulates the growth of the thyroid gland, and it also stimulates it to secrete thyroid hormone. Now, all of these hormones of the anterior pituitary gland are referred to as tropic hormones. And what this means is tropic hormones are hormones that have other endocrine glands as their target. So the pituitary is going to release these glands, these hormones, and they are going to travel through the bloodstream to target cells in other glands. And for thyroid stimulating hormone, that is the pituitary gland. Now, adenocorticotropic hormone, or ACTH, it is responsible for stimulating the growth of the adrenal cortex, which in turn stimulates it to secrete glucocorticoids, mainly cortisol. So here we're talking about the adrenal glands that sit atop the kidneys. Now, FSH is follicle stimulating hormone, and its job is to initiate growth of the ovarian follicles each month. So it's responsible for the process of ovulation. And luteinizing hormone acts in conjunction with the follicle stimulating hormone, and it stimulates estrogen secretion. So it is going to regulate estrogen, and that helps to grow and mature the follicle, and that eventually leads to ovulation, which causes luteinization, or the rupture of the follicle, so that the egg can leave the ovary and then be swept up by the fibria of the fallopian tube. Okay, so we have two more hormones to talk about that are released by the anterior pituitary gland, and that is growth hormone and prolactin. So growth hormone, like it suggests, stimulates growth, and it works the opposite of insulin. Where insulin is released to decrease blood glucose, growth hormone increases blood glucose. And while too much insulin in the blood can produce hypoglycemia, too much growth hormone produces hyperglycemia. If there is a hypersecretion of growth hormone, this can lead to something called gigantism, and gigantism results in acromegaly, which is abnormally large bones of the hands, feet, jaws, and cheeks. And then hyposecretion in children can result in pituitary dwarfism. Now, prolactin is also referred to as the lactogenic hormone, and that stimulates lactation. So it stimulates the breast development during pregnancy, and shortly after the baby is born, it stimulates the secretion of milk. A common type of pituitary tumor that predominantly occurs in women, and they're typically pretty small, is called a prolactinoma. Usually these have effects like any other type of tumor, such as headache or vision changes, lethargy, and nausea. And a lot of times they can be treated with medication or radiation, but sometimes they require surgery. Here is an image of what gigantism or acromegaly might look like. Interestingly, a lot of basketball players that are really tall are diagnosed with to some degree with gigantism or acromegaly. There are two types of hormones that are secreted from the posterior pituitary, which are antidiuretic hormone, or ADH, and oxytocin, OT. Antidiuretic hormone is a hormone that decreases the volume of urine. So it's going to tell the body to hold on to salt, which is water follows salt. So then the body is going to hold on to more water, and therefore it's going to have a reduction of urine output. Hyposecretion of antidiuretic hormone causes diabetes insipidus, which is characterized by excessive volume of urine. Oxytocin stimulates the uterus to contract during childbirth and after childbirth to actually birth the placenta. It also causes glandular cells of the breast to release milk into the mammary ducts. Now, when we're talking about the posterior pituitary gland, the hypothalamus has secretory cells within itself that secrete these two hormones. And then these hormones are delivered via these long axons that protrude into the posterior pituitary. Here's an image that might help further your understanding of how the hypothalamus and the pituitary gland work together to achieve homeostasis in the body. So in this image right here, let me circle it for you. All right, this is what we're talking about. Up here, this part is the hypothalamus. All right, and then the pituitary gland is attached to the hypothalamus by this stalk. Okay, you can see it coming off here. And then here's our posterior pituitary and our anterior pituitary. So, and then up here are these little secretory cells that we talked about that produce the antidiuretic hormone and the oxytocin. Remember, the hypothalamus also produces releasing hormones and inhibiting hormones that also speak to the anterior pituitary and tell it to release those other hormones that we talked about, like prolactin and follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, growth hormone, and the like. So these secretory cells, they're the ones that are responsible for making and secreting the oxytocin and the ADH, and then there's also cells located within the hypothalamus that are going to secrete the releasing hormones. It's going to chemically communicate with the anterior pituitary and tell it to release those hormones using a negative feedback loop typically. And then when the situation in the body has returned to normal, then it's going to secrete inhibiting hormones that's going to tell those processes to turn off. Here's a better picture here, a cross section you can see of the hypothalamus and the pituitary gland and their relationship to one another. And here are just the words, the written words to go along with what I said on the previous slide about how ADH and oxytocin actually is produced in the hypothalamus, and then those hormones pass along axons into the pituitary glands, and the secretion and release of posterior pituitary hormones is controlled by nervous stimulation, and therefore the hypothalamus controls many body functions related to homeostasis, including temperature, appetite, and thirst. The thyroid gland lies in the neck just below the larynx, and it secretes 3 hormones. The first 2 hormones we're going to talk about are the thyroid hormones, and they consist of thyroxine and triiodothyronine, and those are abbreviated as T4 and T3 respectively. Now, where do those little numbers come from? Those little numbers represent the number of atoms of iodine that are in each of those hormones. So it is extremely important that we have enough iodine in our diet so that our thyroid can synthesize these hormones. In the early 1900s, it was discovered that iodine deficiency was kind of running amok, and it was creating increased occurrences of goiter, decreased metabolism, weight gain, fatigue. They were also seeing the impact of iodine deficiency in pregnant and nursing women, and that it impeded the development of the fetus. And it is still to this day the most common cause of preventable brain damage worldwide. So in 1924, the United States decided to start selling salt with iodine in it. And that is the salt, the table salt that we have today, which is iodized salt. We can also get salt from iodine from other sources besides iodized salt. By eating saltwater fish and seafood, kelp, and other types of sea vegetables. Also, cows that graze on grass that is rich in iodine also can serve as a source through dairy, and then vegetables that are grown in iodine-rich soil, we can also get iodine from that. So iodine is extremely important for our thyroid to be able to function properly and synthesize these two thyroid hormones. And these two thyroid hormones impact every single cell in the body. They actually speed up their release of energy from nutrients. So their job is to stimulate cellular metabolism, and this ensures that all of our cells have energy that's readily available for them to do their jobs and to do it properly. The thyroid is unlike any other type of endocrine gland because, for the most part, endocrine glands don't store the hormones that they release. They just release them as they make them. The thyroid is different. The thyroid actually stores the hormones that it makes and suspends them in this fluid as a colloid or like a gel until it's secreted into the blood. Now, calcitonin is the other hormone that the thyroid gland makes, and it is responsible for decreasing blood calcium levels. And how it does that is it inhibits the breakdown of bone, which would release calcium into the body. Here's a look at the gross anatomy of the thyroid and the parathyroid glands. And the thyroid is over here. It's this butterfly-shaped gland that you see here. It kind of looks like a W now that I'm tracing it out. It lies anterior to the trachea. And then on the flip side of that, you can see on the right side of your screen these four little dots here are the parathyroid glands, and we're going to talk about what they do. So next we're going to talk about the differences between hyperthyroidism and hypothyroidism. Now with hyperthyroidism, this is an oversecretion of thyroid hormones, and what is happening here is that nutrients are being consumed by the cells at a really fast rate. So this is increasing the metabolic rate, and individuals that have hyperthyroidism typically have conditions of weight loss. They have increased appetites and can show signs of nervous irritability. They can also appear restless and jumpy and excessively active. It can also cause the eyes to protrude, and this is called exophthalmos, and it is also a characteristic of Graves' disease, which is an inherited autoimmune condition that occurs more frequently in women than men. Hypothyroidism is an undersecretion of thyroid hormones, and there's a variety of different conditions that can cause hypothyroidism. Primarily, it's low dietary intake of iodine, and this causes something called a simple goiter, and I have a picture of it on the next page. But in reaction to low dietary intake of iodine, the thyroid gland will enlarge itself to try to compensate for the lack of iodine. This typically, when it occurs in the formative years, it can cause something called cretinism, and that goes back to when I was speaking about how iodine deficiency is the most common preventable form of brain damage that can occur, and this is related to that. It's characterized by a low metabolic rate, retarded growth and sexual development, and often mental retardation. In adulthood, a iodine deficiency can result in something called myxedema. Again, it's characterized by a low metabolic rate. Remember, we talked about too much thyroid hormone increases metabolic rate, so not enough thyroid hormone is going to decrease metabolic rate. It could also lead to lessened mental capacity and function, physical capacity and function, weight gain, can also affect the skin and the hair. It can also result in an accumulation of a thick mucus-like fluid in the subcutaneous tissue, and this is often noticed most in and around the facial area. I have a picture coming up on the next slide. Here we can see an example of a goiter on the left-hand side of your screen, and then on the right-hand side, this is what myxedema would look like. Okay, so now we're going to talk about the parathyroid glands, and there are 4 small glands that are the parathyroid glands, and they are located on the posterior aspect of the thyroid gland, and they secrete parathyroid hormone. Parathyroid hormone does the opposite of calcitonin. It counteracts it. So calcitonin tells the body to stop breaking down bone, and parathyroid hormone stimulates osteoclasts to begin breaking down bone. So here the body is experiencing a lower than normal calcium level in the blood. So the parathyroid hormone is going to secrete these osteoclasts to start breaking down bone, and calcium is going to be released, and it will enter the bloodstream, and then at the point where homeostasis is achieved, the parathyroid glands will stop secreting parathyroid hormone. So now we're going to talk about the adrenal glands, and the adrenal glands sit on top of the kidneys. They're kind of like these little top hats for the kidneys, and they're a 2-in-1 type gland, similar to when we talked about the pituitary being a 2-in-1. The adrenal gland is also a 2-in-1. There is the cortex, which is the outer portion of the adrenal gland, and the medulla, which is the inner portion of the adrenal gland. So when we're talking about the adrenal cortex, there's 3 different types of hormones that are secreted: glucocorticoids, mineral corticoids, and sex hormones. So the mineral corticoids, typically the hormone there is aldosterone, and I'm going to underline it here for you. And if I can, I'm just going to write a little M to tell us that this outermost zone of the cortex is responsible for secreting mineral corticoids, and when you hear that, think aldosterone. Now the second zone, which is the middle zone of the cortex, they're responsible for secreting glucocorticoids. So again, if I can, I'm going to draw a G. Glucocorticoids, typically cortisol, And then the last zone, which is this zone right here, the innermost zone, the deepest zone, is responsible for secreting sex hormones. So we're going to label that with an S. And that is primarily androgens, which are male sex hormones. We're going to talk about each of those in detail. As I mentioned previously, the most common mineral corticoid is aldosterone. And aldosterone was actually isolated from beef adrenal glands in 1953 by researchers in England and Switzerland. And by 1956, they had an understanding of its structure and its function. And what they discovered is that the kidney is responsible for receiving chemical communication about blood pressure, blood volume, and sodium and potassium levels. And when it detects changes in these various things, then it releases a chemical called renin. And renin is actually what acts on the adrenal gland to tell it to release aldosterone. And the release of aldosterone, what it is going to do is it is going to increase blood sodium and decrease blood potassium. So what this is going to cause is the body is going to hold on to salt. Remember, water follows salt. So the body is going to hold on to water. This is going to increase blood volume. All right. So what is going on here is that the most basic function of aldosterone is that it speeds up kidney reabsorption of water. Now, remember, the aldosterone is released from the outer zone of the adrenal cortex. And now we're going to talk about the sex hormones, and we'll talk about glucocorticoids in a second on the next slide. Sex hormones are secreted from that very inner zone of the adrenal cortex, and we refer to them as androgens. They're a lot similar to testosterone. They're secreted in very small amounts, and they're thought to have a role in the early development of the reproductive organs of both males and females. However, they don't play that huge of a role in males because the testes secrete testosterone, so that kind of overruns that secretion of androgens in the male. However, in the female, it does stimulate sex drive. All right, so as I mentioned before, glucocorticoids are produced in the middle zone of the adrenal cortex. And in this context, when you hear, see, read glucocorticoid, think cortisol, okay? So the main function of cortisol is something called gluconeogenesis. Gluco meaning glucose, neo meaning new, genesis meaning to make, to produce, all right? So this process of gluconeogenesis means the breaking down of different amino acids, proteins, carbs, fats, glycogen, whatever it may be, to increase blood glucose levels. Okay, so that's the main function. It also has an effect on maintaining blood pressure. One way it does this is it, through the help of other hormones, helps to constrict blood vessels, vasoconstriction. Vasoconstriction is going to increase blood pressure because you're increasing the resistance, right, on the wall of the vessel. So vasoconstriction is going to increase blood pressure. It also has some anti-inflammatory, anti-immunity, and anti-allergy effects, which can be good because by bypassing those processes, our body can focus on other things that it needs to take care of in a more timely manner. However, if there are prolonged secretions of cortisol, say due to stress, then this can start to create a problem. We're going to look at that stress response on the next slide. So stress is familiar to all of us. We've all heard ourselves say, I'm stressed, or I'm stressed out, or I'm experiencing stress. So what happens in the body when the body is exposed to some sort of extreme stimuli? That brings on what we refer to as stress. And that puts stresses on our body, and one of the responses to stress is the hypersecretion of cortisol, that glucocorticoid that we've been talking about. So a high blood glucocorticoid concentration is going to have three immediate responses. It's going to increase mobilization of fats and tissue proteins, right? Because those are going to be broken down through the process of gluconeogenesis to make glucose, which is going to lead to hyperglycemia, right? Increased sugar in the blood. Something else that's going to happen is it's going to impact the thymus. And because of that, the body is going to have a decreased number of lymphocytes and eosinophils, which are part of our immune system, and that is going to lead to a decrease in immunity and a decreased allergic response. So now we're not going to be able to fight off those dangerous pathogens that we typically are able to fight off on a normal basis, on a regular basis, when there is not this stress response happening in the body. And then a decrease in allergic responses, that can be bad as well, because our body has an inflammatory response for a reason. And if this inflammatory response isn't working like it should, then that's not alerting our systems, bells aren't going off, right? So that the body can maintain homeostasis like it should and respond to situations like it should. It's getting false readings, right? It's not going to be responding properly. So aside from those types of things, right, this prolonged stress and high levels of glucocorticoids in the blood can also make us more susceptible to cancer. And it can also have other metabolic disturbances and problems associated with it as well. Have you ever gotten up in front of the class to speak and your heart starts beating really fast and your palms get sweaty, or maybe you are somewhere and somebody plays a joke on you and jumps out and surprises you and your heart starts beating faster and you start breathing more heavily? This is because of the hormones that are secreted from the medulla of the adrenal gland. And this is where it gets its name, right? Adrenaline. And adrenaline is also called epinephrine, and the medulla secretes epinephrine and norepinephrine, and this is what is responsible for our fight or flight response. So remember when we talked about the nervous system, that nerve impulses from the sympathetic nervous system stimulate the adrenal medulla, and this is what causes it to go to work secreting these two hormones that cause our heart to beat faster, our blood pressure to rise, more blood is going to be pumped to our skeletal muscles so that they have more energy so that they can react as needed, right, to resist or avoid some sort of threat or attack. So let's talk about some adrenal abnormalities. Tumors can occur in the middle zone of the adrenal cortex or the inner zone of the adrenal cortex. Both tumors occurring there typically result in hypersecretion of the hormones there. So if it were to occur, a tumor were to occur in the middle zone of the adrenal cortex, that can result in hypersecretion of glucocorticoids, which we refer to as Cushing Syndrome. And it's characterized by a moon face, a buffalo hump, elevated blood glucose level, and frequent infections. Now, if the tumor were to arise from the inner zone of the adrenal cortex, that could increase the production of androgens. This is going to enhance the male secondary sexual characteristics like beard growth, development of body hair, and increased muscle mass. If this happens in a female, it is going to be referred to as a virilizing tumor. And because the Latin word virilis, or the term that we use, virile, refers to male or masculinity. Deficiencies or hyposecretions of the adrenal cortex hormones can result in something called Addison's disease. And Addison's disease presents with muscle weakness, a reduction in blood glucose levels, nausea, loss of appetite, and often weight loss. I remember this by Addison's. Add means you need to add more hormones. There's not enough hormones being secreted by the adrenal cortex. Here's a before and after image A with non-treatment of the Cushing syndrome, and then B after a few months of treating the Cushing syndrome. The pancreas is both an exocrine gland and an endocrine gland. It's an exocrine gland because it secretes digestive juices to help us break down our food, and it's an endocrine gland due to the two different types of cells that are located in the islets of Langerhans, and these are the alpha cells and the beta cells. The alpha cells secrete glucagon, and glucagon is responsible for increasing blood glucose, and it does that by accelerating glycogenolysis, which is the breakdown of glycogen in the liver. The liver stores glycogen, and it actually converts glucose to glycogen, and it stores it there, and then when it gets broken down, when glucagon is released because maybe the blood sugar is too low, then through the process of glycogenolysis, that glycogen gets broken down into usable glucose or usable energy that can be transported through the bloodstream into the cells so that the mitochondria can make energy for the cell. Insulin is the antagonist to glucagon. So insulin is going to decrease blood glucose because it's going to attach to the glucose and help it to move out of the bloodstream and into the cells where it can be used. If there is extra glucose after that happens, then it gets turned into glycogen, and it will get stored in various places like the liver, the muscles, and the fat. Here is an image of the pancreas, and you can see that it's kind of tucked nicely in the duodenum, this and the pylorus that's coming off from the stomach. That is the first part of the small intestine. So it's situated nicely so that its ducts open up in to the duodenum there so it can secrete its digestive juices to help us break down food. And then on the bottom, you can see the alpha cells and the beta cells, which are the endocrine cells of the gland, which secrete the insulin and the glucagon. There are two types of diabetes mellitus, type 1 and type 2. Type 1 results from a hyposecretion of insulin. So the islets of Langerhans that are responsible for secreting insulin are not secreting enough of it. This is typically type 1, an individual is born with type 1. Type 2 diabetes is typically adult onset form of diabetes where the target cells become insensitive to insulin and glucose remains in the blood. Now, glucose can't enter cells, and because of that, the blood glucose level rises, and then that also gets excreted in the urine, called glycosuria. Hippocrates was the first to diagnose diabetes mellitus, and the way he did that is by tasting patient's urine to detect its sweetness. So now we're going to talk about the female and male sex glands, and we'll talk about them in a lot more detail coming up when we talk about reproduction and then also the urinary system. So stay tuned, those are very fun lectures. For now, we're just going to talk about how the ovaries contain two structures that secrete hormones. One is the ovarian follicle. Now, the ovarian follicle is the little pocket where the egg develops, and we call that egg the ovum, or ova for plural. So the ovarian follicle is where the egg matures, and then this ovarian follicle secretes estrogen, which is also referred to as the feminizing hormone, and estrogen is responsible for the female sex traits. And once the ovarian follicle ruptures and the egg is released, the corpus luteum begins to develop immediately after that. So immediately following ovulation, the corpus luteum starts to develop, and luteum comes from the Latin word luteus, which means saffron yellow, and the corpus luteum has this really yellow appearance, and it also has fats in there, lipids, so it helps to give it that yellowy color. And its primary job is to secrete progesterone. And what progesterone does is it initiates changes in the uterus that make it more suitable for implantation, like retaining the lining of the uterus. However, if implantation does not occur, then hormone levels recede, and then the inner lining of the uterus is shed through menstruation. Okay, so now let's talk about the male sex glands just briefly. Like I said, we're going to get more into this in later chapters in A&P2. Suffice it to say, some of the cells in the testes, they produce sperm, and other cells that are in between those cells, we refer to them as the interstitial cells. They produce the sex hormone testosterone, and testosterone is responsible for developing those male sex traits. It's also referred to as the masculinizing hormone. Remember, estrogen is the feminizing hormone. Testosterone is the masculinizing hormone. So it's responsible for the development of the external genitalia, beard growth, voice changes at puberty, muscular development, along with the different body contours associated with the typical male. Like I said, we'll talk about it more in chapter 23. For now, just a basic overview that the testes are the male sex glands. The thymus is similar to the adrenal gland in that it has both a medulla and a cortex. And the thymus is located in the mediastinum, and it is responsible for secreting the hormone thymosin. The thymus is also where most of our lymphocytes or T cells are produced, and this plays a large role in immunity. Interestingly, as we age, our thymus really shrivels down and almost becomes like kind of a fibrous, fatty, non-functioning thing. But as we're growing and developing, it's very active in producing these lymphocytes or white blood cells, and thymosin is a collection of hormones, and they work together regarding the development and the function of the T cells, which again is another big player in immunity, and we will talk more about that in chapter 16. During the development of the fetus, the placenta actually serves as a temporary endocrine gland. And aside from secreting estrogens and progesterone, it also secretes chorionic gonadotropins. And this is secreted from a layer that develops around the fetus called the chorion. And it actually is a really important fetal membrane in the placenta. And early on in pregnancy, some of these gonadotropins are actually released into the urine. You might have heard of them as HCGs. And this is what allows us to detect pregnancy early on, is the HCG that is secreted into the urine. So the functions of these hormones is to maintain the corpus luteum during pregnancy. The pineal gland is located near the roof of the third ventricle of the brain, and it's called the pineal gland because it resembles a pine nut or a small kernel of corn. In children, the pineal gland is really easy to find. However, in the adult, it has a tendency to become fibrous and it gets encrusted with calcium deposits, and so it becomes more difficult to find. It secretes melatonin, and melatonin helps with a few things. It helps to regulate our sleep cycle. They think that it also helps with regulating the menstrual cycle in women and also with the onset of puberty in females as well. Sometimes it's referred to as the third eye because it responds to the ganglion cells in the eye, and the amount of light entering the eye tells the pineal gland whether to secrete more melatonin or less melatonin. So during the night, there is an increase in secretion of melatonin, and in the day there is a decrease of secretion. So this is our timekeeping mechanism that helps regulate our internal clock and our sleep cycle. Sometimes there can be situations that happen with the secretion of melatonin if there's a sensitivity. One of those disorders is called seasonal affective disorder, SAD. You might have heard of it as cabin fever, and this has a tendency to happen in places where the winter nights are really long, or someplace like Australia where it's dark for several days in a row. And then this can lead to that cabin fever, which the person can exhibit signs of clinical depression. Sometimes they use lights, bright lights, to treat this, to treat the symptoms of that disorder. Besides our endocrine glands, there are several other organs that do secrete hormones, such as the stomach, the kidneys, the intestine, and other organs such as the heart. In the stomach, for example, ghrelin is a hormone that is thought to boost appetite, slow metabolism, and reduce fat burning. And they think there may be a relationship between that hormone and the development of obesity. The upper chambers of the heart, the atria, they secrete a hormone called atrial natriuretic hormone, ANH, and ANH is an antagonist to aldosterone. So remember, aldosterone is going to tell the body to hold, the kidneys to hold on to water, and that's going to increase blood pressure and other things. ANH actually stimulates the loss of sodium, so the body is going to lose water. That's going to help us decrease our blood pressure. So when there's too much pressure in the atria, then the atria will secrete this ANH as one way of helping to regulate blood volume and blood pressure. And then another hormone, leptin, is secreted by fat-storing cells in our body, and it's thought to regulate how hungry we feel or how full we feel, and they are working with that hormone to see if they can find ways to use it to treat obesity and diabetes and other disorders that involve fat storage. So we talked a lot about the endocrine glands today and what hormones they secrete and some of the actions that those hormones elicit in the body. We will talk about them in more detail as we go through the specific chapters that focus on those systems, and we'll learn about those hormones in more detail and those actual processes that are going on in a cellular level. So thank you for joining this lecture. I know it was kind of a long one. Make sure that you identify your muddy points, and I look forward to discussing them with you in our next Zoom session.